Okay, we should be good.
All right. All right, good evening, everyone, and welcome to tonight's program. My name is Kyle Athide, and I'm the chair of Manhattan Community Board 6. When I was first elected to this position in November 2020, one of my first acts as chair was to establish a standalone health and human services committee. The idea is to connect with our local healthcare providers, to provide accurate and reliable information to the public, and to be proactive in voicing the concerns and issues of our communities. To head this committee, I appointed Dr. Elvie Barroso. Since then, Manhattan Community Board 6, in partnership with NYU Langone Health, have presented the Healthy Living Series, a series of webinars aimed at providing accurate and reliable health information to the public. It is an opportunity to learn from experts and to ask questions. In a world of misinformation and rumors, the opportunity to connect personally with credible health experts can quell the fears we may have. While aspects of pre-pandemic life are returning, we are still dealing with a virus and its dangerous variants. Please continue to exercise precautions. This program is not an end within itself. So I urge all members of the public to continue to educate themselves by listening to verified health experts, not just self-proclaimed experts. I want to express special thanks to Hannah Wade and Stephen Grayson from NYU Langone, as well as their team, all of whom have been wonderful collaborators. In particular, we're grateful to Dr. Felsen and Dr. Simon for being generous with their time tonight. I would also like to thank Dr. Barroso and Marty Barrett from Manhattan Community Board 6 for their leadership in putting together this program. And a special thanks also goes to our board staff, especially Assistant District Manager Brendan Berth, who is crucial to the organization of tonight's program. Now, before we begin, I want to encourage all attendees tonight to attend Manhattan Community Board 6 meetings, which includes committee meetings for health and human services. So please visit www.cbsix.org for more information and a calendar of our upcoming meetings. And we'll put that website in the chat as well. So again, thank you to all for your attendance tonight, for your participation tonight, and your partnership in tonight. And now I turn it over to Dr. Barroso. Thank you.
Thank you, Kyle. As Kyle mentioned, my name is Dr. Elvie Barroso, and I'm the chair of Manhattan Community Board 6 Health and Human Services Committee. I'd like to thank everyone watching at home for tuning in tonight, and I would especially like to thank our wonderful presenters for tonight.
Our first speaker tonight is Dr. Sabrina Felsen. Dr. Felsen is an internist at the Manhattan VA and a clinical associate professor of medicine at the NYU School of Medicine, which both sit within Manhattan's Community District 6. She attended residency at NYU School of Medicine, where she was honored to serve as senior chief resident before joining the faculty at the Veterans Hospital in the fall of 2006. Dr. Felsen continues to see patients in primary care at the VA and until recently was assistant chief of the outpatient clinics. As a primary care leader with expertise in clinic operations, Dr. Felsen was invited to establish a vaccine clinical trial center at the VA under the tutelage of world-renowned vaccine expert Dr. Mark Mulligan and his team. As a co-director of the VA subsite, Dr. Felsen runs COVID-19 vaccine clinical trials in collaboration with NYU Langone Health. Dr. Felsen, if you want to start by sharing your screen.
Let me know if you can see that.
Yes.
Yes.
Is it the right? Okay, good. And it's the right view. It's the presenter. I mean, the poster view.
Yeah.
Yes.
Good. Well, thank you for coming, everybody. I was here once before, so some of you may have been in attendance at the last community board meeting where I presented and let you all know that I lived in this district also for many years until I moved out to Jackson Heights about 3 years ago. Anyway, so thank you for joining again. I think last time we spoke more about vaccines in general and how they worked, and how our COVID-19 vaccines worked in particular, some of them with this new platform now that of the mRNA platform that is so familiar now. But let's move on. Now we're in deeper, a different sort of data set and different quandaries about less about vaccination series 1 and now about booster vaccine. So that's what we're going to talk about today. Okay, is long-term immunity and booster shots. So as mentioned, I'm part of NYU Langone Vaccine Center under Mark Mulligan. And Mark Mulligan has one of 10 vaccine and treatment evaluation units. These are sort of, were set up in the 60s as following experts, vaccinologists, to mobilize quick studies as they needed to happen and just get studies underway with expertise that are needed to do them safely and et cetera. So we're also a member of the COVID-19 Prevention Network that's tasked to lead COVID-19 vaccine research and treatment as well. There are 5 satellite sites of the NYU Langone Vaccine Center. The main site, which is located at Tisch, Langone, Bellevue Hospital's got one, Manhattan VA, where I am, NYU Langone, Brooklyn, and Long Island. Just to revisit this really quickly about how a vaccine works. A vaccine, all of the vaccines basically prime your body with antibodies and immune cells, B cells and T cells that are part of your natural immune system in different ratios, et cetera, depending on the vaccine. But basically, they alert they prepare your body to encounter the wild virus, the foreigner of SARS-CoV-2. And by doing that, you've prepared yourself, you've armed your soldiers, your B and T cells, with what's needed to fight the real enemy, which is the infection. So fight it off and keep you safe if you do get infected. Ideally, to keep you from getting infected as well. But we'll see in this presentation, and you've heard in the news, I'm sure, that those are 2 very different things. By the way, feel free to interrupt me, anybody, as necessary. That's fine. How vaccines are like seatbelts. I like this slide because it really distinguishes between preventive measures. You can think of that as sort of defensive driving, things like hand washing, mask wearing, mouth covering, and they help keep us safe in that they actually prevent the virus from getting in your body in the first place. So they prevent an infection, these measures. Vaccines are like the seatbelt in the car. They're effective, but they need to be in place before an incident occurs. So if an incident occurs, if you're infected, you have your seatbelt on, and this will protect you from getting sick or getting hurt in the car accident. Medications are like airbags in the sense that they're deployed only after a problem has occurred. So if you have COVID-19, if you have the infection, they will protect, hopefully get you better. So keeping safe isn't just about vaccines. And that's been a weird thing because in May, I don't know if you remember, the CDC basically dropped mask mandates for people who were vaccinated. And then in July, they reinstated the recommendation of wearing masks, even if you are vaccinated. And I've seen, and I'm sure you have, a lot of signs around that says masks are voluntary or optional if you're vaccinated. But as the previous slide showed, they really, masks are really helpful in preventing infection. And so it's that extra layer of protection. You don't even need to activate the use of your vaccine if you can prevent the infection in the first place. And masks, hand washing, staying 6 feet apart are all things preventive tools as well to keep you from getting infected. The reason that the mask recommendations were reinstated is because the environment changed. The COVID environment. Sorry, I'm now going to make these slides bigger on my side so I can see them better and look at you at the same time. Sorry. Okay. So our nation's made great progress on vaccinations. If you look here at the slide, you'll see that in the blue there that 183 million people and plus some have been fully vaccinated. That's 56% of the population has been fully vaccinated. If you look at people who are 12 and up, 75%. And if you look at people who are 65 and older, 94% have been fully vaccinated, meaning 2 of the mRNA vaccines or the J&J vaccine. And if you look on the other side of the slide, you're going to see the proportion of people the number of people who got the Pfizer-BioNTech, which is the largest group, versus Moderna versus J&J, and then some other unknown AstraZeneca, and maybe in clinical trials, or who got the vaccine abroad and then came, so they don't fit in our 3 that are EUA approved here. But these are the numbers right now, the current numbers of our vaccinated folks, and these are really clustered, as you know. New York City's done really well. Other places, more rural places, more red states, have not done as well as we have in vaccinating. This is. I'm just going to jump in here. So viruses mutate. So what's important here and what's complicated here, and when we're thinking about COVID-19, which is, now over a year around and evolving itself, and the environment's evolving, and we're evolving, and things are changing. There's so many variables going into the recommendations, which is part of why we're seeing a lot of confusion. But one of the things that's gone into it is, and that we anticipated, is that viruses mutate. That is a normal evolutionary process. They mutate and change over time. It can happen very slowly, or it can happen more quickly. The longer a virus sticks around and the more virus there is, the more replications that occur, the more likely you're going to have viruses changing. That's called a variant. And there's certain variants of concern, meaning variants that seem like they might be particularly worrisome because they have an advantage in their infectivity. They're more infectious, more contagious, deadlier if you do get it. So that can happen, and that has happened. So that we've had gone from being an alpha predominant country to now the Delta predominant variant here. And it's now responsible, as of this summer, starting in July, at about, taking over the variants that's causing COVID-19 here, COVID-19 infections here in the United States. It's now like 99% of infections are Delta. The CDC and the WHO keep track of variants. They process samples of COVID tests and look for the sequence there. The RNA sequence, and by doing that, they can tell if it's a new variant or not, and then track that variant and see if it's exploding in the population or not. There was a clue that was happening in between June and July, when we saw the 7-day moving average that's collected by the CDC explode from about 12,000 cases per 7 days on average in June to 60,000 in July, and to even more now. And that alerted people to something going on. And with the sequencing of samples, it became clear there was this new variant called the Delta variant, and it spreads much more easily. It's more infectious, twice as infectious or more as the original strain. The daily trends and numbers of COVID are accessible to everybody. You just go to the CDC COVID data tracker. This is a 7-day moving average, and you can see here, in November, where we had a big peak, and then things calmed down, and then it went up again here with the Delta variant, and it seems to now be going down some now. But you can see the 7-day moving average currently is 110,000 in this country. So gone up, from the beginning of July with the Delta. One way that infectious disease doctors and epidemiologists talk about infectivity, or how infectious a virus is something called R0. This is a little graph of R0 here, where we're comparing the Delta strain of COVID-19 to other viruses, some respiratory, some not. And you can see on one end, we have the original strain of COVID, which on average would infect a person who had it, a sick person, would infect 3 other people. With the Delta strain, that number, the R0, has gone to an infected person infecting on average 7 people. Now, that's a lot compared to the original strain. It's a lot compared to the flu pandemic in 1918. But it's not a lot compared to measles or mumps. So it is the most infectious of respiratory viruses around right now. And this is a graph just showing a lot of the slides going forward are borrowed from actually the CDC's, the presentation to the CDC that resulted in the guidelines that came out on September 24th. So a lot of those, a lot of the slides you'll see, and I credited them down at the bottom, I just lifted from these expert epidemiologists here. So this is a slide actually showing here, I hope you can see the arrows, I move it. This is the Delta variant increasing in the month of July to now, where you can see it's almost 100% of our infections. And with it, you see that the vaccine effectiveness, how effective are vaccines against infection, not disease, but finding the virus in our nose, how that has gone down as the Delta goes up. So that the age-adjusted vaccine effectiveness against the new COVID-19 infections, it declined from 92%, this is on average of all the different vaccines mixed together, to 73% with the Delta strain, when the Delta strain reached 85% of our current strains. And then the decline ceased with a plateau around 77% efficacy. Not efficacy, vaccine effectiveness. I'm going to explain what that is actually now, because a lot of the slides that we have now and the conversation we have now is about vaccine effectiveness, which is really looking at how effective the vaccine is in real life circumstances. So when the studies first came out with data that was being presented to the FDA for approval, we talked about vaccine efficacy. That's how much a vaccine cuts down on infections, rates of infection in people who got the vaccine versus controls. And it's in a controlled setting, the controlled setting of a clinical trial. And for the WHO, for instance, to approve a vaccine, it must be 50% efficacious. And ours, the vaccines that we got for COVID with these new mRNA vaccines were much, much better than that. Hence the excitement. Vaccine effectiveness can be analyzed once we have the vaccine out in the real world population, as we do now with millions of people vaccinated, to look and see how it performs in real life. That's what we're looking at in these studies. So the Delta variant changed a lot of things, and it's now, as you know, 99% of COVID-19 infections in the U.S. It's at least 2 times as contagious as the original strain of COVID-19. It may cause more severe illness. There's some hints that it does. The COVID-19 vaccines may be less effective against Delta. And vaccinated people can get breakthrough infections with the Delta strains, and probably before. This may be because of Delta, and it may be because of just time since the vaccine was given, the primary series of the vaccine, and so its efficacy is waning through time. So it's not one or the other, probably. So vaccinated people can unknowingly transmit the virus. Transmit meaning spread or infect other people, because vaccinated people can be asymptomatic. They're much more likely to have minimal or no symptoms than someone who's unvaccinated. There is no doubt, there's no controversy that unvaccinated people remain at the greatest risk. And that means they're at the greatest risk of getting infected, getting sick, and dying. All of those, from less severe to the ultimate severity than vaccinated people. So the vaccine, I wanted to look at vaccine effectiveness against Delta, because that's the environment we're in now, is the Delta. And we have the 3 same EUA vaccines that we had originally for the original strain. Are they still effective? This, again, borrowed from our CDC folks here. You can see that vaccine effectiveness against infection, PCR positive, the virus being able to be detected in the nose with minimal or even no symptoms here from screening, has decreased in the summer when Delta became predominant. So the yellow line is Pfizer, and it's decreased the most. But you can see which one's Moderna? I can't see very well on my slide. The orange, that's kind of a weird one. That popped up. I don't have any more recent data on that, but certainly Pfizer, which is what we're mostly talking about now, has gone down. Infection rates, vaccine effectiveness, so infection rates have gone up in nursing homes here, the blue. Healthcare workers are here in green. So vaccine effectiveness has decreased there in healthcare workers and frontline workers and first responders. You can see when you look at hospitalization, so more severe COVID, not just a PCR positive, but symptoms that require hospitalization, you can see the decline has been much less. But again, if you look at the purple, the decline has been more dramatic in the Pfizer vaccine. Here's the Moderna vaccine. It's also declined in vaccine effectiveness in the summer months since Delta's become predominant. But the lowest, but here you can see the decline is much less steep than for infection. These next slides are saying the exact same thing. So again, they're separating out in a different graph form that may stick better in someone else's head or be easier to visualize in someone might like seeing it this way. You can see when you take Pfizer and BioNTech out here, looking at these different, this is looking at different time periods. This is pre-Delta, post-Delta, pre and post-Delta, pre-post, and it's also looking at different age groups. And the only difference that we see is really statistically significant is in age 65 with the Delta strain, hospitalizations are statistically increasing. So the vaccine effectiveness has gone from 86% to 73% in that community of over 65 with Delta. And we see some decline, but not a statistically significant one with Moderna. Now that may be because Moderna started later, and I don't remember, although I bet some people on the phone call do, when it started to be given, but it may be in part that. as well. And it may be just the epitopes, that it may just be more a more potent antibody response, and they stick around longer. This is the same stuff, again, looking at four big studies and then the average of the four, looking at what happens when divided by age group. This is not divided by date exactly, but the dates are mentioned because they're so important since Delta changed everything. But you can see that same like 73% here. And then in different studies, this averages everything pre and post Delta. So it doesn't separate out what's happened more recently. This kind of does. And the other thing about this is all vaccines. Okay, so it's not separating out Pfizer and Moderna. It's all vaccines. And here's our, you can still see that there's a decline of, a decline to 85% from high 90s in the over 65s. And here's another way of looking at all that data, again, from multiple studies, looking at and putting it all together. And I think this slide for me is the one that speaks it most clearly. Look at this is the vaccine effectiveness in real life, looking at for vaccine effectiveness for preventing infection and for preventing hospitalization in red. So if we just look at people over age 65, all comers over age 65, and she's divided out the different studies, you'll see here that for hospitalization, effectiveness has declined for all products for Moderna, but especially for Pfizer, down to the 70s from 87% or so. And then for infection, all products also decline as well, even more dramatically. So the effectiveness against infection is definitely compromised with Delta. Much less clear with underlying medical conditions, really. We do have, it's just much less obvious, much less dramatic in hospitalization. We don't have data on infection. And we do have data on infection rates for healthcare workers. This is 4,000 healthcare workers. I think it's just healthcare, the frontline workers in this study, the HERO study, but we don't have hospitalizations, and the rates were very low and negligible. But with infection, certainly the vaccine is less effective against preventing infection pretty dramatically in frontline workers as well. This all led to the CDC's recommendation on September 24th. And this is the recommendation here. They recommend a Pfizer-BioNTech booster, same dosing as previously, for those who got at least 6 months after the primary series with Pfizer. And this is only for people who got Pfizer. And here's who they recommend it for. People 65 years and older and residents of long-term care facilities. These people should get a booster. As recommended by the CDC. People aged 50 to 64 with an underlying medical condition should get it. People 18 to 49 with underlying medical conditions may get it and should speak with their physician. So this was to allow for some leeway for primary care doctors who know their patients to help figure out if they are if their patient is at increased risk for severe COVID, in which case we would recommend the vaccine. And people 18 to 65 at increased risk for occupational or institutional COVID-19 exposure and transmission may also get the vaccine booster. So this also does not supersede the previous recommendation that people who are really immunocompromised should definitely get the third dose. That's because the first two dose series doesn't work as well in people who have immunocompromising conditions. Okay. I wanted to mention,
Sorry.
Yes.
Sorry to just jump in. I just want to let you know that we want to have time for some questions and
Am I running
Q&A
late?
from the audience.
Yeah,
just
where
if you
am
wanna,
I?
if you're able.
Yeah. Can I do you think I have 5 more minutes since we started late to go through? Is that okay?
Sure, and you can wrap up in 5 minutes. That would be great. So we
Okay.
can have a little
All right.
time for Q&A.
Okay, sure. So I
Thank
just
you.
wanted people. I'm not going to even go through these, but people had these are one of the questions about what were underlying medical conditions for which CDC would recommend a booster, and here they are listed here. Then, so you can see why this is so complicated, because what impacts vaccine effectiveness is a lot of things: age, maybe gender. Don't know that yet. But it does certainly increase harm. And part of this is a balance. And I say it increases harm because myositis, the inflammation in the heart, is much more common in men and boys. Comorbidities impacts the vaccine effectiveness. So people who are immunocompromised may don't mount as much of a response to the vaccines. Living situation, working situation, the initial COVID vaccine that you got, they have different efficacies. Time since your second COVID vaccine, which is why there's a minimum of 6 months, which variant happens to be circulating in your community, how well you're practicing and others around you are practicing additional safety measures, because you may get more virus. The load might be higher that you're exposed to if people aren't wearing masks around you. So COVID-19 booster shots, there was a lot of confusion around this, but I think we are coming to some consensus. The process is that the FDA reviews safety and effectiveness data. They make a recommendation then to the CDC. They also have a advisory committee on immunization practices, which issues booster dose and interval recommendations. And they came up with a recommendation as well. And there was a difference about FDA had recommended for healthcare and essential workers to get the booster. The ACIP did not. And then Rochelle Walensky overruled that and said, yes, I do, on September 24th, agree to give this vaccine, to recommend the vaccine to first-line workers. And so that was where some of the confusion came in for people, is in that situation. She didn't like overruled, but the data is complicated and it's a judgment call, and so that's what it was. We don't know really yet about how effective real life, again, vaccine effectiveness is going to be for the third dose. What will that do for us? We don't know. We have a couple small studies from Israel where they rolled it out in June to 60 years and older, and we have some Pfizer data from phase 2-3 trials that looks at immune responses. And it shows that basically the booster does mimic what happened with the primary series in terms of your antibody production. Okay. Basically, our data is then, our recommendations are based on modeling, in part, modeling benefit and harm. Here's the modeling for benefit based on big data sets, 4 different studies that I'm not going to go into because I don't have time. But basically, you can see here, if you look at 65 and older, you need to vaccinate 481. You need to vaccinate with a booster 481 people to avoid 1 hospitalization and 125 to avoid an infection. And these are the numbers for 18 to 29. So you need to vaccinate 8,738 to prevent a hospitalization and 105 to prevent infection. One thing is, you can see everybody's getting infected kind of in equal numbers, but hospitalizations are happening really differently in different ages. This is the number needed to vaccinate to prevent 1 hospitalization over 6 months. The booster is in blue, primary series is in green, and you can see it was very, you need to vaccinate 10 times more people now at age 65 to prevent hospitalization, and 22 times more in 18 to 28 to prevent hospitalization, which to me brings us back to how important getting vaccinated with the primary series is. That's really the biggest bang for your buck. Although this is important too. I think it's pretty compelling as well. 481 people vaccinated with a booster to prevent a hospitalization. Worth it to me. But I'm just saying, if you're not vaccinated, you're really going to benefit from getting vaccinated. This is our current vaccine center studies. There's a lot going on. If you have any interest in hearing more about it, the next slide has the phone number to call, which is, I hope you can see here, 877-919-2822. If you're interested in any of the vaccines currently going on. And I'll end with that. So thank you very much. And I'm going to go back here just so you can see what some of the trials are here. Thanks. Sorry about that I went a little over.
So,
Go ahead.
yeah, thank you for your comprehensive presentation, Dr. Felson. We will now turn to questions from the audience that have been submitted through the Q&A feature of Zoom. Marty Barrett, who is a CB6 member and a member of our Health and Human Services Committee, will ask questions he has, as well as questions from the Q&A feature of Zoom.
Okay. Dr. Felson, one of the attendees has asked, will the Moderna vaccine have half the dosage? And if so, will it be as effective as the Pfizer?
Right. So we don't know. I think Moderna has just submitted and J&J is going to. I don't know that data yet. The Pfizer vaccine is being dosed at the same dose that it was initially dosed, 0.3. I think the booster for Moderna may be as well, but I don't know the answer to that. I know some of my colleagues are on. I don't know. Nora Henderson, do you know the answer to that? I'm going to call you out. Yeah, I'm not positive about that. We don't know yet.
Do you know when the Moderna and the J&J additional shots will be available?
They're going to go through the same process here that Pfizer did. So you're going to have first will go. It's in the hand. Moderna, I think, is in the hands of the FDA now, and their data. So I think they are reviewing that. I think J&J, or I might have them reversed, will in the next couple of weeks also. But it'll be a public thing again, just as Pfizer was. And we haven't seen, certainly with Moderna, really, we have not seen that decrease in hospitalization, and with J&J as dramatically as we did with Pfizer. J&J wasn't as efficacious to start with, but we haven't seen the decline as dramatically. I see another question. Sorry.
Oh, okay. Do you anticipate that we will need to be vaccinated every 6 months indefinitely?
I don't know about every 6 months because there's so many factors that go into this. Because, like I said, it may, as it becomes more endemic and more like the flu, there may be there may no longer be a need to be boosted because there's not as much around. Because there's more immunity that we have around. So it really isn't clear yet whether or not it's going to be every 6 months or every year. I wouldn't be surprised, or every 2 years. I wouldn't be surprised if it becomes part of the ACIP's recommendation for kids, just like that it becomes just one more of the routine vaccines. But we don't know the interval yet.
How long do natural immunities last for those who've got COVID? Does vaccination increase the resistance to infection?
We know that vaccines, we know that the vaccination is recommended for people who've had the natural infection because it is more protective. It's also, it may be more protective in that it may boost the immunity that you already have there. The immunity from somebody who's had the infection probably never goes to zero, but this is all a continuum, and there's no absolute, there's no way to say exactly. It probably depends on how how severely ill you were, what, your own immune system. So we know that there's durability to it, but we know that adding the vaccine on top boosts it and is better than not doing that in terms of preventing infection, hospitalization, symptomatic COVID. If you think of those things, I would really think of infection and symptomatic COVID as two, or severe COVID as separate things.
We're continuing on. I just want to quickly flag something that Nora Henderson said with regards to something that was said earlier.
Yeah.
Which was, she said that Moderna has a larger dose than Pfizer for the EUA 2-dose series, I believe. So I just wanted
Moderna's dose is 0.5 mils per, but and I think, but they do have more mRNA in it, which may be why we're not seeing. Yeah, it's 30 micrograms. Oh, so here she's writing, I see. Pfizer was 30 micrograms, while Moderna was, I thought it was 50 micrograms. But she may be talking about the mRNA in the vaccine. And I think that is actually one of the reasons why it's thought that Moderna is maybe longer lasting in its effectiveness, is because there was more mRNA delivered initially in the vaccine.
Another question from an attendee. The person had breast cancer, which and chemo for it, which ended 8 years ago. Are they considered immunosuppressed?
Immunosuppressed, immunocompromised. One, congratulations, because you've passed the major mile mark, right? In over 5 years. So congratulations on that. That's fantastic. I mean, the cancer is included. A history of cancer is included on underlying conditions. I think that, for a female with breast cancer, really myocarditis is so unlikely, and that's the major harm that we're seeing. A lot of people with the third doses got some lymphadenopathy, but it went away within days. And in general, the reactogenicity, meaning the fever, the feeling under the weather, like you have the flu, was actually milder with the third dose of Pfizer, is what they've seen so far. So the harm is so minimal that I think it's worth it to get the booster. And if you're comparing your immune system to somebody who is currently on cancer treatment, chemotherapy, or someone who's currently on treatment for rheumatoid arthritis, you're certainly not immunocompromised. But if you're comparing yourself to someone who's never had chemotherapy, then you are at increased risk. And I think that you should speak with your oncologist or primary care doctor. But I can say that they're very liberal in who is defined as having an underlying medical condition in the CDC website.
And one last question. Can someone who received the Moderna 2 shots get the Pfizer third shot? What would be the effects?
Well, we don't know. There's studies going on that are called the heterologous booster studies, where they're combining different types of people who got Moderna getting Pfizer, people who got Pfizer getting Moderna, getting J&J, et cetera. There's studies looking at that. The studies are smaller. The studies are harder to do because, as you can imagine, if you're a Pfizer executive, you want a Pfizer booster. So to combine, these aren't industry studies anymore where these are happening. They're happening academically. Probably nothing would happen. It's not being recommended. It hasn't been studied or published or available. The data is not available to do it. Again, I think the data is there that people are really well protected if they got Moderna first off. We're not seeing a big drop off in terms of vaccine effectiveness. And so I would wait.
Thank you. Stephen?
So thank you, Dr. Felsen. Our next speaker is Dr. Naomi Simon. Dr. Simon is a professor of psychiatry at NYU Grossman School of Medicine, vice chair for research, faculty development, and mentorship, and Director of Anxiety and Complicated Grief Program and Senior Advisor to NYU's Stephen A. Cohen Military Family Center. She has over 20 years experience conducting clinical translational research in anxiety, complicated grief, and stress-related disorders. She's deputy editor of Depression and Anxiety, the official journal of the Anxiety and Depression Association of America. She completed her MD at Harvard Medical School, residency at Columbia, consultation psychiatry fellowship at Massachusetts General Hospital, and a master's in epidemiology from Harvard School of Public Health. So it's my pleasure to introduce you to Dr. Naomi Simon. Dr. Simon, you can share your slides.
I realized I was muted and I couldn't get myself unmuted. Can you hear me now?
Yes.
Yeah.
Perfect. Okay, now I can share my screen. Sorry about that. Well, first, it's an honor to be here, and it's really a wonderful opportunity to share information about mental health that sometimes is ignored, and there can be, stigma about talking about feelings and emotions and mental health conditions. But really, we think about this as inherent as who we are as people and part of our biology and psychology together. So I think it's really wonderful that you're including this in your health series. My background, as you heard, is in a range of anxiety, trauma, stress, and grief-related conditions. Today, we're going to focus on grief. And I think it's a nice segue from talking about how we can protect ourselves against infection with COVID. We'll be talking about a little bit now some of the difficult situations of the losses that have been occurring as a result of COVID and what we understand about it kind of in the field, in psychiatry and mental health, and also just some ideas about how we can help each other in the community and how to think about when this does become more of a mental health professional issue or when we can support each other as a community in different ways to think about that. This is just to give you some of the background of some consulting and grants that I do. Most of my work is in research and academics. Nothing related to anything I'm going to speak about today. This first point is really just that, as you all know, loss is universal. So no one can get through life without some exposure to the loss of someone they know over time. And it's really one of the most traumatic experiences when it's someone who's close to us, because we can have both a traumatic distress, kind of this is a major trauma to us to have this occur, maybe unexpected, even if it isn't. It's an important part of our lives. And also there's an attachment when it's someone who's close. We don't think about separation response so much in adults, but it does occur in adults as well when you lose someone who's close to you, just like when you think about with small children having separation response when they separate from their parents. But everything that we're talking about right now is in our normal, healthy functioning. So when there's bereavement, which means the loss, there is some form of acute grief. There isn't one way to grieve. Everyone grieves in different ways for different amounts of time, but ultimately they go from a very intense acute state of grief to a more background, or what we call kind of integrated grief, meaning it's kind of integrated into your life. It's not that you stop missing the person or never have sad memories or grief related to the person, but it changes. So it's not right in the front of everything, and you sort of come to terms that the person is gone. So we call that accepting the reality. You change your relationship kind of in your heart and your mind with the person who's no longer there, kind of coming to understand that they're not present, and they're present in your memories or other ways you may connect with them, and depending upon your religious beliefs. But also importantly, that you're able to envision something in your life without that person in a more positive way. And those are what we call kind of a healthy transition to a more integrated background grief. But as I mentioned, I work with all kinds of stress, trauma, and loss. And I think it's helpful to think about the fact that bereavement is a major life stressor. And so it's not surprising that bereavement or the loss of someone close, just like other kinds of traumas and major stresses, cause a whole range of stress-related mental health conditions, from depression to post-traumatic stress, substance or alcohol use, excess use, or other kinds of medical or psychiatric mental health conditions. And it's actually been, interestingly, quite controversial for many years in the formal fields of mental health and psychiatric diagnostic criteria, whether we should even be allowed to have a diagnosis related to grief, given that everyone has grief and grief is normal. So it was unclear kind of where to make the lines, and are we kind of adding stigma or medicalizing a normal thing? And so it's actually only about to be launched through the American Psychiatric Association this year. I'll show you some of the criteria. And the international group that does this, decisions about these things, ICD, only launched some guidance for clinicians how to diagnose these things in the past year. So what I'm showing you here is kind of the rates of prolonged grief after a death. And we really don't know that well, but we think it's in the range of around 7 to 10% of people. These are much more detailed than you really need to read in detail, but just to give you a sense of kind of where they cut some of these lines in the American Psychiatric Association criteria, you're seeing them, but they're actually not going to be formally released to everyone in their kind of diagnostic criteria set until next March. So you're ahead of the game, but I can tell you these are what they are. But basically there were decisions like you have to be at least 12 months out since the death occurred, because anything in that 12-month period was considered kind of normative to have that intense level of grief. The international criteria use 6 months, thinking that you can tell these things apart. But really the way we do psychiatric diagnoses is that there's a combination of persistent and distressing symptoms that interfere with people's lives, cause substantial distress, impairment in functioning. And some of the core kinds of symptoms are feeling as though the person has died themselves, feeling like they cannot believe that the death is actually real. So you wake up each morning and feel like you're just learning about it anew. Avoiding reminders that the person is dead. So that may disconnect people from their loved ones or activities that they used to do with the person who died. So for example, a spouse may no longer feel comfortable going out with other couples because it may be too painful a reminder. Intense emotional pain, trouble moving on with their lives in any way, feeling emotionally numb, feeling like life is meaningless, which is a risk factor for suicide, and intense loneliness. So those are the core features of what are in this kind of diagnostic criteria set. But again, I think it's important, again, to remember that every type of death, even within an individual, is different because the relationships are different and where you are in your life at that time is different. And so there isn't one normal way to have grief. And in COVID, we have some extra issues to keep in mind. Some of this is that COVID infections can occur in families, and who gets very ill from COVID or dies even from COVID, it's not always obvious why. Now we're learning more and more over time about what some of those risk factors are, and you've heard some of that in the prior talk. But all of these things can cause confusion and complication around whether you see just an acute grief or prolonged grief or depression or other types of symptoms. And I think we've come as a field in medicine to realize we're doing a better job later now in the pandemic than we did in the beginning when we didn't know so much about this, that there's certain things that are very important. Like even if you cannot be there with your loved one in the hospital, for example, or in the ICU, to come up with some way to say goodbye or have a connection and to have that happen, even when people are not nearby. We want to also watch out for survivor guilt. So this idea of like, what if I was the one who infected them, or how come they were ill, or if I had known earlier, maybe they wouldn't have died. And these are normal thoughts that people have after loss that we can, try to support them around because it is, not someone's fault that someone else died as a result, and whatever the underlying medical reasons that happened. The other practical challenges are interference with our normal practices that support people, and these vary from different religions and cultures, but they're actually extremely helpful and potent. So, burial ceremonies, funerals, all these things bring social support and people together around a shared loss and provide a place where people can talk together, cry together, and share memories together. And that was less able to happen when there's social distancing requirements, and particularly earlier in the pandemic. And we actually know that social support is what we call a resiliency factor that helps people to get through hard times. And that's not just for death, that's for really any time. And I'm sure all of you have some time in your lives where can think of an example where that helped, to have someone close to you be there as a support when something difficult was happening. So again, just some of the, I think awareness that we're trying to share is that COVID deaths themselves and just the pandemic itself is putting people more at risk for not accessing some of these healthy supports that normally happen in our culture and religions and through friendships. And that it's something we want to think about very actively, how to creatively support people if you can't do the usual way that you do something. And also that there can be other consequences of the death related to fear of infection, having other people to care for, financial worries, and so forth, that we want to just be sensitive and aware of. And also as a field, think about how to support people. And it's interesting, it's not specific to COVID. There's actually some research that came out from 5 different studies interviewing people around Ebola, that when there's a pandemic, the themes that impact loss are having multiple losses, being uncertain or having sudden losses and unclear who dies and who lives, why that might be is not always understood, having that chance to say goodbye, not being able to do the normal supportive things or have the usual memorialization. And in these studies, what people felt was helpful was to come up with ways for social connection. So to find a space for that, even if it's a different way than you normally would remember the loss or come together, to find creative ways to honor what are traditions and rituals, even if some of them are planning to defer them, to have ways to connect with people and share memories is extremely helpful. And then also to have support around care-related decisioning. So to be included in that when you have a close family member who's critically ill. And these same themes are coming out now in COVID studies, as came out in those Ebola studies around the rituals, being alone, feeling things are unfair, unexpected, how to live in the context of stressors, and to find these alternative rituals or make meaning, and have a chance to talk about your feelings, really. And another study interviewed 48 families, and they recommended the same thing. Most important things are to find ways to be able to access saying goodbye, connecting with your family members, no matter what the situation, ICU, infection risk, or otherwise, to be creative and find ways to do that. And I think it's important also just to highlight we do have to keep in mind that there's just a tremendous volume of loss that's gone on around COVID around the world. And this is one researcher who kind of did this simulation saying that, we talked about in the last talk about how many people might be infected here, that there were probably on average about 9 close attachments for every COVID test. So if you think about that, given the rates of COVID, 4.7 million worldwide, there's about 42 million COVID bereaved worldwide and about 6.2 million in the US alone. So being aware, part of this is preparing to support people and the mental health sequela that's probably going to go on for some years to come. So, if we think about prolonged grief disorder that I was telling you, which is kind of the grief that gets stuck and, may get to a point where we need some therapy or other interventions from professionals to help people. Being somewhere around 10%, we're talking about, 4.2 million new cases in around the world. So, and this is not accounting for some of the other factors. So this is really partly that we need to be aware. A lot of times doctors don't even ask patients about losses in their lives. So, educating the communities to feel comfortable to raise their distress to their doctors as well. The American Psychiatric Association put out some recommendations really just for psychiatry, even how to think about this. And part of the big recommendation is to screen people who are at risk. So if you have someone who already has a lot of difficulty handling stresses in their lives from other pre-existing depression or anxiety disorders, those people may be at greatest risk of having trouble coping with yet another major stressor. But a lot of it is really around helping people understand that intense emotions are normal. Sometimes people have not experienced that type of emotion until they've lost someone who's close to them and they feel like they're losing their mind and going crazy in some way, when it's really a normal process and allowing people a space that's safe to express how they feel, but also to have a break from the intensity of those symptoms and be able to have some time just to relax, enjoy themselves, have positive memories, be supported to do something pleasurable, helps people to be able to eventually make that transition so that they're not spending all of their time in that intensely sad state and can think about a future without that person. So really the same themes are around how to strengthen relationships, even if it's virtual in these kinds of times, giving people space if they want to talk about the death, to have that space. And that doesn't have to be with a professional. That can be with a whole range of people, close friends, clergy, support groups, helping people learn to live with those reminders and giving them some kind of sense of connection to those memories. Because first people think only about the death itself, and it's hard to remember the positive memories till you go through that. And this is just to give you a general kind of public health. We wrote an article about this way that we think about it, which is really that at the bottom of this pyramid is helping support people in the community to be able to have access to these kinds of resources in the community and amongst themselves, but also to have policies that help us to integrate screening and assessment so that as people come into the next level, which is having some symptoms and going to their primary care doctors, that they're getting asked questions about this and people know how to think about it in the clinical fields. And then it's only the top of the pyramid where people really may benefit from professional help. And this came out as very similar recommendations from a European Association for Palliative Care. So they work with death and dying. And they put it even more specifically, saying that if you're at very low risk, low need, we can provide education about normal grief and what to expect, when to worry, that can be done through a whole range of ways: leaflets, self-help information, peers, family members, friends, frontline workers, and so forth. The next level is working with clergy who frequently work and are more comfortable with issues of death and dying, community groups, trained volunteers who can serve as supports, in part just helping provide social support and overcome some of that intense loneliness and helping people find have a place to talk. And then the next level being more trained professionals. So in summary, we're talking about this in the time of COVID because this is an unprecedented pandemic that has both caused an increased number of deaths in a very scary and unexpected way within family clusters. But also it's interfered with some of our normal coping. And the strategies that we have had over, generations amongst families, cultures, religions. So there's actually a lot that can be done to try to be aware of that and reach out to people in your own community, to think creatively if there is a loss in your own circles and families of how to give people the space that they're not getting because some of those traditions are not occurring, and to think kind of creatively about that. And then in the public health sphere, we also need to be thinking about how to expand both knowledge amongst primary care and mental health providers about when to identify, how to identify risk factors and when prolonged grief might be present that could benefit from a more evidence-based formal psychotherapy approach. And we do have diagnostic assessments as well as some scales that are starting to be available to help clinicians as well. They're generally not developed yet for patients to make a diagnosis themselves, but people certainly could look at them. It's something that would be better to talk to a primary care doctor about. And we definitely have more work to do to be able to get some of those resources out to people. So I will stop there and stop sharing so that I can take questions. But thank you very much for your attention and for including this topic in your series.
Thank you for your comprehensive presentation, Dr. Simon. So we will now turn to questions from the audience and have been submitted through the Q&A feature of Zoom. Marty Barrett will ask questions he has from the speakers, as well as questions from the Q&A feature of Zoom.
Thank you, Dr. Simon. How can you distinguish usual grief from prolonged grief disorder?
Yeah, so there are a few different ways that we can do that. One is time. So there were some sites in the development of that criteria set what it should be called, and they agreed on prolonged grief being the big hint that there needs to be at least extended period of time. So someone may come in and feel extremely intensely sad, tearful, and so forth in the first month or two, but that would not be considered prolonged grief. I think the other key major factor is that the symptoms are present for a good part of the day, most days, and interfere with functioning or cause substantial distress to the individual. And then there are the specific diagnostic criteria that I showed you, but I think those are the kind of the high line ways to think about it.
What things do you worry about that suggest someone might need professional help?
I think in psychiatry, with prolonged grief, just with other conditions, just more confusing because grief itself is so intensely distressing. But we wouldn't want to, for example, say you cannot get professional help because you are only 6 months or 12 months since the loss. So if someone is feeling, for example, that they might hurt themselves, and maybe at risk for suicide, that would be an immediate referral to get professional help to help keep that person safe. And I think the same thing, if people are having persistent difficulty with their functioning or severe distress such that they feel they cannot tolerate the moments that they're in, those would be signs to refer for professional help. And then I think the other thing would be, even if you have longer periods of grief and you're not at that level of intensity, if you've tried other things, like you've tried speaking with people in your community, accessing the resources that you may have, or even being in a grief support group, and that has not helped, that would be another sign that it might be time to, try to seek professional help. And I think it's sometimes people feel like, how do I get mental health care? It's so confusing. It's good to remember that if you have a primary care doctor, that is a good place also to start. They can help you with referrals.
What less formal approaches can be helpful to people who feel alone in their grief if they don't need or want to seek professional help?
Yeah, so I think some of this is really around the social support. So things that help people have social support and to come together with other people so that they are not as alone or isolated. So, there may be more formal things like grief support groups that are available on the internet, as well as less so in the pandemic live, but in people's communities to access your, if there's a clergy or other religion that you're a part of, to access the resources in that community. And then also for really just allowing oneself to do things with other people can be another less, not formal, but thing that can be helpful to get people to not be alone and only thinking about their loss.
But during the pandemic, when there's social distancing restrictions, what can someone do?
Yeah, so I think during the pandemic with the social distancing restrictions, the first thing is when there's an acute death, that there are actually many ways that people can still They may not be the traditional rituals, but they can still have memorials. They can still have, Zooms like we're having today with interaction or going out and bringing people together outside. And all, as well as online forums and other things like that, can still be helpful. And then I think for people who, if you're, referring to how can you help someone in your community with their restrictions, some of it is just opening the door. So letting people know that you are a willing ear to listen, because a lot of times what happens is after that immediate period of loss, people feel like no one else wants to hear anymore because they've moved on, but the person who's suffering has not moved on. But letting people know that you're there, periodically, to remind them anytime you want to talk, I'm here just to listen.
Is there a resource in New York where people can find therapists trained in evidence-based approaches?
Yes. So, and I should have said that some of my slides over the years are adopted from my good colleague, Dr. Catherine Shear, who's right up at Columbia here in New York. And she runs a center that does training and education called the Columbia Center for Prolonged Grief. And part of what they have on their website through a funded grant is to list people who have been trained in formal treatment for prolonged grief disorder. So it's something people can look there. But I think it's important to note that that's a somewhat limited resource, and most clinicians have some training. Most mental health clinicians have some training in dealing with grief. So, people should not limit themselves to that. But if you're trying to find providers with the specialty training, there's actually a lot of information as well about prolonged grief disorder on that website as a result of the grant funding. So it's a wonderful resource.
Thank you, Dr. Simon.
You're welcome.
So thank you again to our wonderful speakers, Dr. Sabrina Felsen and Dr. Naomi Simon. It means a lot that the two of you have taken time out of your busy schedule to inform our communities about the COVID-19 vaccine, as well as dealing with grief and family loss from COVID-19. I would also like to thank our board chair.
Thanks for having us.
Yeah, thank you very much.
Yes. So I would also like to thank our board chair, Kyle Atide, CB6 member, Marty Barrett, CB6 assistant district manager, Brendan Burt, and Hannah Wade and Stephen Grayson from NYU Langone Health for their help in putting together tonight's program. And lastly, thanks to all of the attendees for your participation, thoughtfulness, and care of these subject areas. I hope that you share this information with your networks. This program has been streamed on YouTube for ease of shareability. And I encourage everyone to attend other webinars in our series on healthy living in the community. The next event is in the webinar series will happen on Wednesday, October 27, and a link to register for the event is being posted in the chat now. And good night and stay well. Thank you very much.